What is postural orthostatic tachycardia syndrome, POTS? Download PDF copy. By Syed S. A. Reviewed by Danielle Ellis, B.Sc. Causes and symptoms. Epidemiology. Diagnosis and treatment. References. Further reading. Postural orthostatic tachycardia syndrome, POTS, is a common heterogeneous form of cardiovascular autonomic dysregulation. The exact cause of POTS remains unclear. Patients typically complain of weakness, dizziness, rapid heartbeat, and palpitations when standing. Women in their adolescence or early adulthood, who are often in the middle of education or beginning their jobs, constitute the majority of those affected by POTS. The disorder can be highly disabling and financially ruinous. Image credit, Creative Cat Studio /Shutterstock.com. Image credit, Creative Cat Studio /Shutterstock.com. Causes and symptoms. The etiology of POTS is mainly unclear. Different theories surrounding the syndrome's genesis have been developed due to the heterogeneous symptomatology, early age at the beginning, and the presence of potential triggers in the patient's past. The three primary hypotheses are that POTS is either an autoimmune condition with unusually elevated sympathetic activity and excess catecholamines, a sympathetic denervation resulting in central hypovolemia, or a reflex tachycardia. Early clinical observations indicated that the onset was comparable to Guillain-Barré syndrome and that the sickness frequently began with an acute infection, usually viral. This has drawn attention to the speculative but hardly ever substantiated notion of immunological involvement in POTS. This is backed by the fact that autoimmune diseases typically have female preponderance and temporal associations with prior virus infections, vaccinations, or trauma. Additionally, POTS patients commonly display signs of immune system dysfunction and positive autoimmune test results. An autoimmune basis has been proposed as a possible cause of POTS. Several autoreactive IgGs have been discovered, including the ganglionic acetylcholine receptor, GAChR, voltage-gated potassium channel complex, and cardiac lipid raft-associated proteins. Other suggested pathomechanisms include issues with autonomic cardiovascular control, abnormally elevated sympathetic activity, excess catecholamines in the blood, peripheral sympathetic denervation that causes central hypovolemia, and abnormally elevated sympathetic activity. This hypothesis proposes that peripheral sympathetic denervation would cause venous pooling and lower preload, which would result in compensatory heart rate elevation, while increased central sympathetic outflow would explain insufficient sinus tachycardia. Chronic orthostatic intolerance is the hallmark and pathognomonic symptom of POTS, which is frequently made worse by additional factors like high ambient temperature, inadequate fluid intake, dehydration, physical strain, early morning hours, or fever. However, POTS patients frequently experience a wide range of additional symptoms. Upon POTS first manifests, dizziness, weakness, a quick heartbeat, and palpitations when standing are the most often reported symptoms. Additionally, syncope, weariness, stomach pain, and headaches are noted. It is unknown if extravascular volume depletion and deconditioning in patients with additional autonomic symptoms contribute to POTS. However, GI problems are persistent in POTS patients. The pathogenesis of POTS is complex and includes volume dysregulation, deconditioning, excessive sympathetic drive, and defective sympathetically mediated vasoconstriction. Epidemiology. Postural orthostatic tachycardia syndrome, one of the most widespread types of orthostatic intolerance in the world, the prevalence ranges between 0.2% and 1% in developed countries. It is estimated to impact about 500,000 patients in the United States. POTS primarily affects younger people, with an 80% female gender predominance. Young, premenopausal Caucasian girls between the ages of 15 and 45 make up the vast majority of POTS patients, with the bulk of cases being diagnosed between the ages of 15 and 25. Diagnosis and treatment. When evaluating a patient with suspected POTS, it's important to confirm the diagnosis, look for comorbid disorders, and rule out anything that could be the origin of or closely resemble the autonomic syndrome. Orthostatic intolerance symptoms, the severity and scope of other autonomic conditions, further potential arrhythmia, potential contributing effects of medications or dietary supplements, and other comorbid diseases must be established by a thorough clinical history. Image credit, Horacio Selva /Shutterstock.com. Image credit, Horacio Selva /Shutterstock.com. For clinicians and affected patients, the heterogeneity and broad spectrum of POTS-related symptoms present a significant problem. Additionally, due to POTS' poorly understood pathophysiology, treating the disease's underlying causes is practically impossible, and care of the condition is typically centered on symptom relief. POTS' long-term prognosis has not been thoroughly studied. About half of all POTS patients are thought to spontaneously recover between 1 and 3 years. An accurate diagnosis is the first step in the proper management of POTS. The syndrome should be fully explained to patients. After the diagnosis, the patient should get full education regarding non-pharmacological treatments that relieve symptoms, long-term prognosis, and therapy options suitable for the patient's condition. Paying proper attention to the environment's temperature, engaging in strenuous exercise, or right after eating can prevent acute exacerbation of symptoms. Medications that aggravate orthostatic tachycardia and sinus tachycardia should be stopped when possible. Among them are norepinephrine reuptake inhibitors and stimulant medicines. Typically, medical professionals evaluate various medications to reduce heart rate, enhance peripheral vasoconstriction, and boost intravascular volume. However, pharmacological therapy only has limited overall results, and even when multiple medicines are used, the disease still profoundly impacts the most symptomatic patients. Exercise that improves cardiovascular fitness and steps to raise effective blood volume is also crucial. Non-pharmacological therapies can be sufficient in some situations. Additionally, medical facilities and professional bodies need to ascertain whether the diagnostic criteria for POTS, which are overly comprehensive, have caused a problem since they have an extremely high diagnostic sensitivity but relatively low diagnostic specificity. What is Jervell and Lange-Nielsen syndrome? Download PDF copy. By Syed S. A. Reviewed by Danielle Ellis, B.Sc. History. Cause and symptoms. Genetics. Epidemiology. Case reports. Diagnosis and treatment. References. Further reading. Jervell and Lange-Nielsen syndrome, JLNS, is a rare cardioauditory disorder with an autosomal recessive pattern of inheritance. JLNS was first reported in Norway in 1957. Bilateral sensorineural hearing loss, a prolonged QTC interval, and a high risk of sudden cardiac death are some characteristic features of JLNS. It's a type of long QT syndrome, LQTS, passed down through the generations. Image credit, Juan Resende /Shutterstock.com. Image credit, Juan Resende /Shutterstock.com. JLNS is one of the most severe heart rhythm abnormalities, and it can result in sudden death in young individuals. JLNS is caused by mutations in the KCNQ1 or KCNE1 genes that are homozygous, or compound heterozygous. History. Anton Jervell and his colleague Fred Lange-Nielsen presented the first report on a familial illness defined by a considerably prolonged QT interval, congenital deafness, and a high incidence of sudden cardiac death in childhood in 1957. This instance involved a household in which 4 of 6 children, born to unrelated parents, died unexpectedly as children. Cause and symptoms. Mutations in the KCNE1 and KCNQ1 genes cause Jervell and Lange-Nielsen syndrome. JLNS is a congenital condition passed down through the generations in an autosomal recessive pattern. About 90% of Jervell and Lang-Nielsen syndrome cases are caused by mutations in the KCNQ1 gene. Almost half of all individuals with JLNS have symptoms before age 3. A congenitally deaf kid with syncopal episodes during periods of stress, activity, or panic is the classic presentation of Jervell and Lang-Nielsen syndrome, JLNS. Congenital, bilateral, profound, and sensorineural deafness are types of deafness reported in JLNS patients. More than half of children with JLNS who are not treated die before age 15. The QT interval is frequently quite long, greater than 500 milliseconds, and is linked to tachyarrhythmias, such as ventricular tachycardia, torsades de pointes, TDP, ventricular tachycardia, and ventricular fibrillation, that can result in syncope or sudden death. With the exception of calmodulin-related LQTS, patients become symptomatic much earlier in this variant of LQTS. Intensive or sudden emotion, competitive sports, panic, or jumping into cold water cause cardiac episodes in nearly 90% of patients. Patients with JLNS who have KCNQ1 mutations had longer QT intervals and are more likely to have arrhythmic episodes than those who have KCNE1 mutations. Genetics. Mutations in these genes cause potassium channels to lose their normal structure and function or prevent them from forming. Hearing loss and an abnormal heart rhythm are symptoms of Jervell and Lang-Nielsen syndrome, which are caused by alterations in the movement of potassium ions in the inner ear and cardiac muscle. The KCNE protein family consists of 5 members, KCNE1, KCNE5, each of which is a tiny single-pass integral membrane protein with a residue count ranging from 103 to 177. These genes direct the production of proteins that work together to generate a channel across cell membranes. Positively charged potassium atoms, ions, are transported out of cells through these channels. The flow of potassium ions via these channels is essential for maintaining proper inner ear and heart muscle activities. Epidemiology. The prevalence of the illness varies greatly depending on the demographic investigated, but it affects between 1 and 6 people per 1 million people worldwide. Denmark, Norway, and Sweden have an abnormally high incidence of 1 in 200,000 due to established genetic features. In Turkey, there have also been reports of a rise in the number of cases. Case reports. They describe the case of a 10-year-old Moroccan boy who presented with recurrent episodes of syncope after being born with congenital hearing loss and a drastically prolonged QT interval. He is the firstborn of a healthy consanguineous couple who both hail from Morocco's northwest. There was no history of sudden death, deafness, syncope, epilepsy, or any hereditary diseases in the family. Image credit, Bangkoker/Shutterstock.com. Image credit, Bangkoker/Shutterstock.com. The pregnancy had been medically monitored, and there had been no difficulties. His mother had no previous history of medication use or phytotherapy. His birth weight and length were normal, and he showed no indicators of dysmorphia. On auditory-evoked potential testing at 6 months, he was diagnosed with severe bilateral SNHL. At the age of 24 months, he had his first syncopal episode. An echocardiogram revealed a structurally normal heart. A adrenergic blocker was given to the patient right away. His parents and 2 younger siblings, aged 7 and 1 years, were all clinically normal. Sanger sequencing analysis was used to evaluate the complete coding region and flanking intronic regions of KCNQ1 and KCNE1 for molecular genetics. The index patient was found to have a homozygous frameshift mutation as a result of this. This mutation was found in both parents and 1 sibling. The frameshift mutation was not found in the family's youngest kid. The discovery of the genetic substrate in this patient verified the clinical diagnosis of Jervell and Lang-Nielsen syndrome, allowing us to provide him with proper management and genetic counseling. Furthermore, this discovery adds to our knowledge of genetic diseases in the Moroccan community. Diagnosis and treatment. When JLNS is suspected in a child with congenital deafness and syncopal episodes, the QTC interval is measured to see if it is longer than 500 milliseconds. The diagnosis is confirmed when pathogenic mutations in KCNQ1 or KCNE1 are found. A single gene test, a multi-gene panel, or complete genomic testing can all be used to find the genes. The degree of the disease should be determined once the diagnosis has been made. A professional hearing evaluation, geneticist consultation, complete blood count to check for anemia, and detailed family history should all be included in the evaluation. A beta blocker is the first-line treatment for syncope, cardiac arrest, and sudden death. Metoprolol has been demonstrated to be inferior to propranolol and nadolol in preventing cardiac events. The most widely accepted opinion is that nadolol is the best option. An implanted cardioverter defibrillator, ICD, should be placed in patients with a history of cardiac arrest. ICDs are also used in patients considered to be at high risk. A QTC interval of more than 550 milliseconds, syncope, before the age of 5, and a guy older than 20 years with the KCNQ1 pathogenic variation are all symptoms observed in high-risk individuals. How advanced flow cytometry could transform cell and gene therapy. Download PDF copy. View supplier profile. Request further information. Sponsored content by Sartorius May 5, 2023. Reviewed by Alex Smith. Cell and gene therapy is an extremely promising area of biomedical research, with many breakthroughs and treatments that target genetic disorders and cancer. Although this area has seen rapid growth, companies encounter technical challenges and high costs regarding the phenotyping and profiling of cell products. This article focuses on the role of flow cytometry in developing chimeric antigen receptor, CAR, T cells and how advanced systems may enhance workflows and facilitate bringing new therapies to the bedside. How advanced flow cytometry could transform cell and gene therapy. Image credit, Sartorius. What are cell and gene therapies? Cell and gene therapies are utilized to treat diseases and, in some cases, cure diseases by targeting the underlying proteins or genes. Overlaps between these therapies are present, but they remain in different fields. Cell therapies utilize living cells derived from a donor, allogenic, or the patient, autologous. For example, stem cell therapies treat blood and bone marrow diseases. Gene therapies input genetic code into cells to repair the function of a missing or defective gene. Glibera was the first gene therapy approved in the USA and Europe to treat lipoprotein lipase deficiency, a rare genetic disorder. What is CAR T cell therapy? CAR T cells are an area of biomedical research that has garnered significant attention. They lie at the intersection of gene and cell therapy. CAR T cells are gene-modified cell therapies that communicate with a specific surface protein on the tumor cell, causing cell death. This targeted treatment method is favored over traditional chemotherapies and has effectively treated blood cancers like lymphoma and leukemia. How advanced flow cytometry could transform cell and gene therapy. Image credit, Sartorius. Development of CAR T cells. The CAR T cell development process begins with isolating T cells from a patient or a healthy donor. The cells are reprogrammed to express the CAR construct, which identifies the target antigen on the tumor cell surface. CAR T cells then expand before administration to the patient. Like any gene and cell therapy product, CAR T cells need functional and phenotypic characterization at each stage to ensure they are effective and safe. Role of flow cytometry. Each stage of CAR T cell development utilizes flow cytometry, which can be utilized early on to identify specific populations of the donor T cells associated with a better prognosis for CAR T cell therapy. Subsequently, the cells are continuously characterized for safety, quality, and function until they are transferred to the patient and throughput follow-up monitoring. The many ways in which flow cytometry analysis is utilized in the development and manufacturing of CAR-T cells include the following: identification and quantification of cell composition in the donor sample, evaluation of CAR expression on the therapeutic cells, quantification of tumor expression of immunosuppressive and antigen molecules, assessment of cell functionality and viability, estimation of effector cell activation and cytotoxic killing, monitoring of cell persistence and therapeutic effect in the patient. Limitations of conventional flow cytometry. Phenotyping, purifying, and expanding immune cells extracted from patients is technically complex and expensive. Conventional flow cytometers that analyze cell and secreted proteins are low throughput and cannot support pharma-level data generation. There is a demand for linking insights gained from immune cell health, phenotype, and proliferation to cytokine secretion profiles from the same sample. The main weakness of conventional flow cytometry is the fragmented data analysis workflows that delay progress. Advanced flow cytometry simplifies workflows. To address these limitations, numerous scientists have considered advanced flow cytometry. These advanced flow cytometry systems provide throughput, speed, and more data per assay well. For example, employing the IK Advanced Flow Cytometry platform enables immunophenotyping data with measurements of bead-based cytokine secretion and cell health in a single experiment. This requires fewer samples and prevents the need for multiple assays. Advanced flow technologies integrate powerful software for immediate access to real-time data, improved visualization tools, and dynamic gating capabilities, allowing easy interpretation of complex datasets. Conclusion: advanced flow cytometry offers terrific value at many stages in developing and expanding gene and cell therapy products, such as CAR-T cells. Multiplexed analysis in a single well enables modern laboratories working on the subsequent breakthrough immunotherapy to simultaneously learn about immune cell function and phenotype in a single well. About Sartorius. Sartorius is a leading international pharmaceutical and laboratory equipment supplier. With our innovative products and services, we are helping our customers across the entire globe to implement their complex and quality-critical biomanufacturing and laboratory processes reliably and economically. The group companies are united under the roof of Sartorius AG, which is listed on the Frankfurt Stock Exchange and holds the majority stake in Sartorius Dedham Biotech SA, quoted on the Paris Stock Exchange. This subgroup is comprised mainly of the Bioprocess Solutions division. Innovative technologies enable medical progress. A growing number of medications are biopharmaceuticals. These are produced using living cells in complex, lengthy, and expensive procedures. The Bioprocess Solutions division provides the essential products and technologies to accomplish this. In fact, Sartorius has been pioneering and setting the standards for single-use products that are currently used throughout all biopharmaceutical manufacturing processes. Making lab life easier. Lab work is complex and demanding. Despite repetitive analytical routines, lab staff must perform each step in a highly concentrated and careful way for accurate results. The Lab Products and Services division helps lab personnel excel because its products, such as laboratory balances, pipettes, and lab consumables, minimize human error, simplify workflows, and reduce physical workloads. Sponsored Content Policy. News-medical.net publishes articles and related content that may be derived from sources where we have existing commercial relationships, provided such content adds value to the core editorial ethos of news-medical.net, which is to educate and inform site visitors interested in medical research, science, medical devices, and treatments. Immunoprofiling to decode the humoral immune response. Download PDF copy. View supplier profile. Request further information. Sponsored content by Syngenix May 1, 2023. Reviewed by Maria Osipova. Chronic diseases, such as cancer, neurological and autoimmune diseases, are complex and challenging to diagnose and treat due to their intrinsic heterogeneity. This means patient responses to current therapeutics vary, with many patients not responding or displaying severe adverse reactions. Immunoprofiling for humoral immune system decoding. Image credit, BioRender. Biomarkers support early detection, predicting harmful outcomes, disease endotyping, stratifying responders and non-responders, and enhancing clinical trials. Although any objectively measured biological molecule can be a biomarker, antibodies provide a direct measure of disease compared to commonly employed measures, such as RNA, DNA, and proteins, which may result from any process that occurs in the body. Antibodies are an early and direct effect of illness. Utilizing immunoprofiling to decode the information in the humoral immune system provides direct insight into the disease state. Antibodies are excellent biomarkers because they are indicators of disease, appearing early, frequently before symptoms are present, and continuing to appear throughout the disease duration. Antibodies occur early in disease and are abundant, target-specific, and straightforward to obtain from sera. Antibodies can flag illness much earlier than numerous diagnostic tools that are currently used. Self-proteins can become autoantigenic when disease-associated changes occur, such as genetic mutation or ectopic expression. Unexpected post-translational modifications, splice variants, and neoantigens, among other variations, can also be autoantigenic. Diseases like ALS and cancer initiate aberrant host protein expression and antibody production. TDP-43 tangles produce antibodies in ALS, and tumor-associated antigens in cancer may become autoantigenic. 5-10. In 2003, Arbuckle et al. Studied blood samples from U.S. military personnel with lupus. They detected the presence of antibodies in the sera up to 9 years before the lupus diagnosis. 1 Antibodies also show great prognostic promise. 4, 7, 11. Patel et al. Performed an antibody screen on a non-small cell lung cancer patient group. They identified a panel of 13 antibodies highly predictive of poor 5-year survival rates. 9 In a second group, the same panel demonstrated no significant difference from the original group while retaining high sensitivity and specificity. 9. Chronic diseases impact many organs. The humoral immune system is constantly surveilling the whole body and creates antibodies associated with disease expressed in different tissues. As a result, the antibody repertoire varies across individuals. Antibody signatures, combinations of predictive antibodies, can be determined and produce higher diagnostic and prognostic value in comparison to single antibodies, RNA, or DNA. 6. The discovery of potential disease-related protein pathways that are valuable for target deconvolution and drug discovery may be enabled by antibodies. Antibodies are highly specific, identifying precise discontinuous antigen epitopes. 3.8 They are excellent biomarkers due to their disease and antigen specificity. Protein arrays need full-length, correctly folded proteins that exhibit specific, biologically relevant epitopes to best capture antibodies. The Syngenix Iome protein array has over 1,600 properly folded proteins, all expressed with patented KREX protein folding technology. Because the humoral immune system is constantly surveilling the body and indicating changes with antibodies, immunoprofiling provides valuable information regarding the disease state and serves as an important source of biomarkers.